Pulmonary manifestations of liver disease. First, hepatopulmonary syndrome. It is a widened alveolar arterial oxygen gradient en route with or without hypoxemia that occurs due to intrapulmonary vasodilatation in the presence of hepatic dysfunction or portal hypertension. Advanced liver disease is not necessary for the development of HPS. The pathogenesis. There's dilatation of pre and post capillary pulmonary vasculature. There's impaired oxygenation of venous blood. There's increased pulmonary production of nitric oxide, which is the primary thing responsible. So in the presence of liver injury and portal hypertension, what happens is endothelin 1 is released, there's bacterial translocation, TNF-alpha is released, endothelial nitric oxide synthase is activated, and there's nitric oxide produced. That causes the vasodilatation. Clinical features include dyspnea, platypnea. Platypnea is increased dyspnea on standing, and orthodeoxia is hypoxemia, which is increased on standing. This is due to increased vasodilatation and shunting of blood in the lung bases when the patient is upright. You will find clubbing, cyanosis, spider angiomas more in patients with hepatopulmonary syndrome than in other cirrhotic patients. The chest X-ray is usually normal, but it can show signs of lower lobe interstitial infiltrates which look like interstitial lung disease. The pulmonary function test spirometry is usually normal and there is a preserved lung volume. But the DLCO, the lung capacity to diffuse carbon monoxide, is reduced markedly. But this is not a very sensitive or a specific test because it is reduced in cirrhotics in the absence of HPS as well. The diagnosis of HPS requires 1. The presence of an ABG abnormality in which the alveolar arterial gradient of oxygen is more than 15 to 20 millimeters of mercury with or without hypoxemia, which is PaO2 of less than 70 millimeters of mercury. Plus, the second requirement is documented pulmonary vasodilatation. Now, how do we do that? There are 2 tests we could do. One is a bedside test. Agitated saline is injected IV and bubbles will be visible on a contrast Doppler echo. And where do we find the opacification? In the RV within seconds, the right ventricle within seconds. If there is an intracardiac shunt, the contrast enters the left ventricle within 3 heartbeats or 3 cardiac cycles. But if there is an intrapulmonary shunt, which is diagnostic of HPS, contrast enters the LV or left ventricle in more than 3 cardiac cycles. So that's called a delayed shunt. If there is no shunt, the bubbles are absorbed by the lungs rapidly. The second test we can do is a lung perfusion scan. It's a technetium 99 MAA scan, which is a macro aggregated albumin. We give that IV, and normally all particles are trapped in the lungs. But in HPS, and this is a very specific test for HPS, which is present even in the presence of lung disease. We can diagnose it even in the presence of lung disease. Few particles escape through dilated capillaries and they lodge in the lung beds, and therefore they get taken up and they get seen everywhere, like the cerebrum and all. So a positive scan is when the shunt fraction is more than 6%. Screening for HPS should be done before a liver transplant, because if there is a shunt, if there is HPS, the patient moves higher up on the liver transplant list. There is a high mortality if the patient is not transplanted early. And this is the only proven treatment. The liver transplant is the only proven treatment. And it does work, though the patient takes about 1 or 2 years to actually recover from it, but they do recover. Portopulmonary hypertension, POPH. The definition is mean pulmonary artery pressure more than 25 millimeters of mercury plus, proving that elevation is not because of left heart failure or anything else. And how do we do that? We do a pulmonary capillary wedge pressure, which will be less than 15 millimeters of mercury in the setting of portal hypertension. So the prerequisite for portal pulmonary hypertension is portal hypertension. It's not just any cirrhotic. High risks patients would be females, those with autoimmune hepatitis as the cause of the cirrhosis portal hypertension. Lower risk is seen in HCV etiology. The pathophysiology, there is increased portal pressure, there's a hyperdynamic circulation, increased vascular shear stress, and portosystemic shunting. The histopathology would be smooth muscle hyperplasia, hypertrophy, concentric intimal fibrosis, and necrotizing vasculitis, as seen in primary pulmonary artery hypertension as well. The clinical features, the majority of patients are actually asymptomatic. And when they do have symptoms, they initially have dyspnea on exertion. It's progressive, then they develop pedal edema, they develop chest pain on walking. And you will find an increased JVP, a loud P2, a pansystolic murmur in the tricuspid area indicative of a tricuspid regurgitation. And all these findings are also seen in primary pulmonary arterial hypertension. The ECG would show right atrial enlargement, right ventricular hypertrophy, plus or minus an RBBB. The best screening test would be a transthoracic Doppler echo, and this would show an increased mean arterial pressure. What would be the next step? A right heart catheterization. We check the pulmonary capillary wedge pressure. It should be less than 15 millimeters of mercury. Lots of medical treatments have been tried, but nothing is so effective. People have tried phosphodiesterase 5 inhibitors like sildenafil, endothelin receptor antagonists like bosentan. Now, this does not entirely reverse with liver transplant, unlike in HPS. In fact, if the mean pulmonary artery pressure is more than 35, the peri-op mortality in liver transplants is very high. Liver transplants contraindicated in patients in which mean pulmonary artery pressure is more than 35 millimeters mercury due to POPH.